Thank you for joining us today for our live video conference on Nursing Perspective, Supportive Care for the Oncology Patient. I'm Richard Payne, Professor of Neurology and Chief of the Section of Pain and Symptom Management at MD Anderson Cancer Center in Houston, and I will be your moderator for today's program. I would like to begin our program by welcoming our studio guests, starting with Dr. Faith Ottery, President of Ottery & Associates, Oncology Care Consultants in Philadelphia, Pennsylvania, and Dr. Deborah Thorpe, Clinical Nurse Specialist at MD Anderson Cancer Center here in Houston. In addition, Carol Curtis, Clinical Nurse Specialist, and Dr. Lillian Nail, Associate Professor and Associate Dean of Research for the University of Utah College of Nursing, will both join us later in the program to answer questions and make comments relating to their presentations. Today's program will include 4 pre-taped presentations, followed by a live panel discussion on each topic. We'd like to encourage our audience to participate in our program by calling our toll-free number, which will appear at the bottom of the screen. Operators are standing by to take your questions, which we will answer during the live discussions. I would also like to take a moment to welcome our viewers who have joined us on the Internet. We encourage everyone to participate in this program and future programs on MEDIVISION's website. Visit MEDIVISION's website at www.medivision.com to join us during this program. Anyone participating in the live Internet broadcast may also submit questions by email, and we will try to answer as many of them as time allows. If you would like to review this program after the initial air date, the rebroadcast can be accessed at MEDIVISION's website later this month. Now I'd like to turn our attention to the first presentation. In this presentation, I will actually be focusing on new therapies for pain, acute pain and breakthrough pain as the major topics. Acute and chronic pain are a major public health problem in the United States. This is broadly in a variety of painful conditions, but also as it affects cancer patients. In fact, there is much data to suggest that many millions of patients are affected by pain. For example, there are some 20 to 30 million operations or surgical procedures done per year in the United States, many of them on cancer patients. And the available data suggests that a fully 50% of patients who have surgical procedures will have poorly relieved pain if just simply given intramuscular injections of analgesics such as Demerol. Cancer affects nearly 4 million people a day, and the World Health Organization statistics report that approximately 25% of patients worldwide die at home or in hospital without relief of severe pain. So that undertreatment of cancer pain is quite common. In fact, a study done in the United States and reported in the New England Journal of Medicine by Cleland and colleagues in 1992 reported that fully 46% of ambulatory cancer patients in this study were undertreated for their pain. The undertreatment of pain has major economic and major economic consequences and major consequences in human suffering. But if one just looks at the economic consequences of undertreated pain, there are many billions of dollars lost in direct and indirect cost because of inability of people to work and to be productive members of society. It's estimated that approximately 500 million workdays per year are lost by full-time workers because of unrelieved acute and chronic pain problems. The barriers to pain management are many. As one might ask, why would this problem exist? Well, actually, there are many barriers to more adequate pain management. Perhaps the most fundamental barrier is the lack of knowledge on the part of clinicians. Generally speaking, medical schools, nursing schools, pharmacy schools, professional schools have done a poor job at educating us in how to assess and manage pain. And in fact, when physicians were queried in the cancer studies that I mentioned as to how it was that 46% of the patients would be undertreated, physicians said that the number one reason for the undertreatment was the inadequate pain assessment skills. Generally, one could also point to a low priority being given to the assessment and management of pain and other symptoms as a major barrier. The exaggerated fears of addiction with the use of potent analgesic compounds such as opioids is often cited as a barrier to a more adequate treatment of cancer-related pain. In fact, some have accused us of being an opiophobic society with respect to the use of opioids such as morphine for the management of pain. Another major barrier that has been raised is the undue influence of restrictive laws and regulations on the practice of medicine. Laws and regulations which generally restrict the availability of opioids and other controlled substances for the management of pain, and which have the effect of intimidating physicians and other healthcare providers in the use of these compounds. Now, if one looks at other barriers to pain management, there are some medical and clinical barriers that are also important. Eduardo Barrera and others have characterized some of the clinical characteristics which might predict refractory pain problems. These clinical barriers include incident or movement-related pain, patients who have pain from a neuropathic pain mechanism as opposed to a somatic or musculoskeletal pain mechanism, patients who are severely psychologically distressed and who have pain, and patients who have a history of psychological dependence or substance abuse disorders coincident with their pain problems. These major characteristics in patients have also been found to be important barriers to optimal pain management. I would like to focus the last few minutes of my presentation on some of the newer aspects of pharmacotherapy which look at the better treatment or more optimal treatment of incident pain and neuropathic pain in particular as a way to improve these conditions. For example, if one looks at incident pain, which is defined as a transient exacerbation of pain above the baseline level of pain, usually triggered by movement, one of the major barriers to more optimal treatment of incident or breakthrough pain is the fact that patients often cannot get an adequate amount of analgesics into their system in a time frame that is consistent or appropriate for the rapid increment in their pain. So the idea is that a patient who is moving and who has pain in anticipation of movement really needs some medication that would act very quickly, generally within a few minutes of administration. Most orally administered drugs require oral absorption and therefore take often 30 minutes to achieve peak effectiveness. There has therefore been much interest in developing novel formulations of analgesics which can work very quickly and which don't require the absorption through the gastrointestinal tract. One such formulation, a fentanyl lozenge, actually has been recently approved by the Food and Drug Administration for use in this country, which really involves sucking on a fentanyl preparation that would provide analgesic blood concentrations within 5 minutes of administration. And in fact, this formulation may provide a significant advance in the treatment of breakthrough or incident pain. There are also newer non-steroidal anti-inflammatory drugs which have been approved recently for the management of acute pain. One such drug, bromfenac sodium or Duract, is a non-steroidal anti-inflammatory drug which has the potency of some of the weaker or World Health Organization or WHO Step 2 opioid analgesics. For example, in the clinical trials in which provided the basis for bromfenac sodium or Duract being approved for use for acute pain, it was shown that a 25 milligram capsule of Duract was equivalent to approximately 2 Percocet pills or to 2 50 milligram tramadol or Ultram pills. So so this advance in pharmacotherapy of pain, that is to say, the availability of more potent non-steroidal anti-inflammatory compounds to treat acute pain, will also improve overall our ability to manage pain in cancer patients. Neuropathic pain, or pain which results from lesions or injury to either the peripheral nerves or the central nervous system, such as the spinal cord, is also cited and by clinical experience is a significant problem. One of the problems with treating neuropathic pain is that the current medications that we have just are not efficacious enough. For example, it was recently shown in a meta-analysis evaluating the effectiveness of tricyclic antidepressants for neuropathic pain that really only about 30% of people who take tricyclic antidepressants for neuropathic pain get 50% pain relief or more. Yet these drugs are really considered now first-line therapy for neuropathic pain. Therefore, the development of other agents for neuropathic pain would be a significant interest and advance. One such agent, clonidine, a alpha-2 adrenergic compound, has been approved by the Food and Drug Administration for epidural administration. And clonidine had, in the phase 3 pivotal trial, demonstrating its efficacy relative to epidural morphine, actually showed that when patients were stratified with respect to their predominant pain mechanism, that patients with neuropathic pain were in fact more likely to respond to the administration of epidural clonidine than were patients who had pain from other mechanisms. So the availability of epidural clonidine now within the past 6 months also represents a recent advance in our ability to manage neuropathic pain. Let me conclude by saying that another advance in our ability to care for patients with pain, and particularly for patients with cancer pain, really relates to the cancer pain initiative movement that has occurred in the last 10 years. Cancer pain initiatives are generally statewide, grassroots initiatives of healthcare professionals and patient advocates who come together to advocate for better management of pain in their areas. These cancer pain initiatives can act as referral sources for patients. That is, they often know where the centers of excellence of pain treatment are in a particular region, and publish numbers for patients to have so that patients can be referred to local experts for their cancer pain management. And also, these cancer pain initiatives serve as resources for regulators in a given state or region, and in fact have served as advisors to, for example, medical boards when medical practice acts were amended or rewritten so that the drug regulations in a state were consistent with promoting good medical care and not inhibitory to the practice of good medicine. So although pain is undertreated and cancer pain is undertreated, the good news is that with improved pharmacotherapies and the availability of these advocacy groups such as the cancer pain initiatives, that we are likely to see in the future great improvement in our ability to manage patients with cancer-related pain. Well, we've actually already received several questions from our viewers, and I'd like to ask our panelists here to respond to some of these. One question from Atlanta, Georgia asked, based on recent clinical studies, which new drugs show the best results in treating breakthrough pain in immunocompromised patients? Perhaps I'll start off since I just discussed breakthrough pain. There's no substantial difference between immunocompromised patients and patients with normal immunity in the prevalence or incidence of breakthrough pain. And as I indicated in my presentation, the availability of a rapidly acting drug such as oral transmucosal fentanyl citrate should be a major advance in the treatment of breakthrough pain in immunocompromised patients as well as in patients with normal immunity. Debbie or Faith, would you like to add anything to that?
I'm just curious because I really haven't known that much about the fentanyl lozenge. In terms of the immunocompromised patients, a lot of times there's oral mucosal problems. Does that change the absorption?
Yes.
And are there any issues in terms of what's in the lozenge in terms of mouth care, in terms of cleanliness, etc.?
Well, that's a very good question.
Thank you.
All of the clinical studies which demonstrated efficacy for oral transmucosal fentanyl, of course, based on the assumption that there was an intact, normal oral mucosa. Fentanyl is rapidly absorbed across a normal oral mucosa. It's unclear what the absorption of fentanyl is in a damaged mucosa or a patient with active mucositis. And at this point, I don't think we could recommend using oral transmucosal fentanyl in patients who have an active mucositis. There are really no implications for mouth care. This is basically a lozenge with fentanyl embedded in this sweetened matrix, and patients simply suck on this lozenge, and the fentanyl is released and absorbed in the saliva and through the mucosa.
But because of the sweetened component, if someone has issues of, they've had head and neck radiation, et cetera, are there any issues that they should, after they finish the lozenge, do anything particularly in terms of mouth care?
No, not really. It has a mild raspberry taste, and it's well tolerated really by all the patients who used it. Debbie, do you have anything to add?
I think probably it would be difficult for a patient with mucositis just mechanically to do the sucking on the lozenge, so probably they need another method of pain management. In terms of oral care, I think whatever oral care regime the patient is on would be satisfactory.
We have someone from the internet, from Albuquerque, New Mexico, who's given us a question. Is there an interaction between antiemetics and pain drugs in oncology patients? If so, which antiemetics show the least interaction, and with which pain drugs? Debbie, you want to start out? Well,
there's a pretty common and overrated expectation, I think, that antiemetics will enhance the analgesic effect of the opioids, and very often they're given in combination with that expectation. I find sometimes this is just another reason not to give as much opioid as the patient might really require to effectively manage the pain. There is certainly a very important role for antiemetics in the treatment of pain patients. Very often they have nausea, may be related to the opioid itself, may be related to other factors such as chemotherapy, or very often the decrease in GI motility and constipation. And so very often patients do require an antiemetic. And I don't believe there's any one in particular that I would recommend. It's a matter of identifying and targeting the specific symptom the patient is experiencing, and finding an antiemetic that is effective for the patient's problem.
Right. I sometimes use metoclopramide. I have the sense that is a little less sedating than the phenothiazine antiemetics, but that really needs to be better studied.
There's also some expectation that it may improve motility to some extent, which is a common problem in patients on opioid medication.
We have time for one more quick question during this discussion period. This comes from Omaha, Nebraska. In a surgical cancer patient at home and receiving home care, what suggestions do we have for the nurse in the home care setting to monitor the success of the pain treatment regimen? What practical things can a nurse do quickly to help monitor pain management treatment?
Well, the best thing is to assess the pain on a regular basis, make sure that the patient knows how to use a simple pain rating scale, such as a 0 to 10 scale, and ask them before and after an intervention what their level of pain is, and be able to document that. If someone is not in the home regularly with the patients can be taught to keep a diary.
Great.
Anything to...
Those are two very good suggestions, and I think documenting the severity of pain is critical. We must break from our discussion now for a few minutes and turn our attention to the next presentation. But before we go, I would again like to encourage all of our viewers to call in questions using the toll-free number at the bottom of the screen, or for those who are participating in this program via the internet, you can email your questions over the web. We've gotten some good questions already.
Hello, I'm Carol Curtis, a clinical nurse specialist consultant from Greenfield, Massachusetts. The focus of our program today is on supportive care issues, specifically pain, nutrition, and fatigue. These are important issues for individuals throughout the cancer experience, whether that be at diagnosis, through therapy, during terminal care, and that's where we're most familiar with these issues, or for cancer survivors. In other words, the issues of supportive care cross throughout the cancer trajectory. In the little bit of time we have today, I'm going to highlight the principles of effective cancer pain relief and suggest some strategies of improving practice within your work setting. Dr. Payne already discussed with you the scope of the problem of unrelieved cancer pain. Unfortunately, unrelieved pain is still common and persistent, and yet with the knowledge, skills, medicines, and technology we have in this country, needless suffering from cancer pain need not be a part of the cancer experience. This is an important issue because when we look at cancer patients with pain, they often fear pain more than they fear the cancer itself. How often have you heard people say to you, "It's not so much the cancer that bothers me. I'm afraid I won't be able to deal with the pain." As we look at these issues, wherever it is in the cancer trajectory, effective pain management is a patient right and professional responsibility. You can help achieve this goal. As you listen today to the principles for effective pain management and strategies to suggest change in your practice, ask if your work setting measures up to the standard. If not, start today, putting the pieces together to increase the visibility of pain and to make unrelieved pain unacceptable within your work setting. So what is good pain management anyway? In this area, it's pretty easy because there is consensus. The American Pain Society, the Agency for Healthcare Policy and Research, the Oncology Nursing Society, the American Cancer Society, and all 50 states with cancer pain initiatives agree. Good pain management involves a multidisciplinary process. None of us can do it alone. It also requires us to respect that the individual with pain is the expert on their pain and pain relief. Not you or not me. The person with pain is the single most important piece of assessment data in understanding pain and pain relief. Assessment is key to managing pain well, and that's assessment of both pain and pain relief. If you're only assessing pain, you're assessing half of the package without assessing relief. Assessment needs to be systematic, ongoing, individualized, and in writing. Do you have a standardized tool within your setting? If you do, is it regularly used? And is there action taken when pain is unrelieved? These are places where you can start to improve practice today. Titration of medicines to individual relief is also a principle of effective pain management and key to success. We need to combine medicines with non-drug complementary interventions to increase comfort as well. Part of the principles for pain management ask us to evaluate the process continuously, to look at how well we're really doing. What's the scope of practice in terms of pain management and scope of the problem of unrelieved pain within your setting? How much is too much pain for an individual to endure? How long is too long to wait for relief? These should be in writing and part of the policies and procedures for practice in pain management. Who's accountable for pain relief in your setting? And if someone is accountable, is it in writing? If it's not in writing, it's likely that you're like most of us, and no one is ultimately accountable for poor relief. Within your work setting, what triggers a review? Many of us use a scale of 0 to 10 and identify a pain rating at level 5 or above twice consecutively as an automatic reason to review the plan, a requirement that the plan be looked at, not the individual. The best plan is bound to fail if we don't communicate among ourselves as well as with patients and families. We need to make sure we all understand the plan and that the individual that we have given it to is able to follow the plan effectively. Let's talk about assessment for a minute because it is one of the keys to successful pain management. It helps us plan and select interventions, and it also provides a baseline to determine outcomes. And each of us is being asked in today's healthcare system to identify outcomes of our practice. What are we doing? How are we doing? And how well? What to assess? There are several areas: pain, pain relief, the effect of pain on the person, side effects, and the overall plan. How well is this working? Let's go back and talk about pain for a minute. The more we know about pain, the more we can identify interventions that will work. So the classic questions we always ask are things like onset, location, duration, what makes it better, what makes it worse, what's the quality, what's the severity, is this new pain? The greater picture that we can paint, the better we will be able to identify interventions that work. We also want to look at differentiating between acute pain and chronic pain. Most of us learned acute pain behaviors, that the person in pain has vital signs changes, that they grimace, they moan, they guard muscles. But that's mostly caused by the sympathetic nervous system. And over time, with persistent pain, the sympathetic nervous system adapts, causing the vital signs to stay steady and normal, even in the face of severe pain. And the individual may have a mask-like expression that simply looks sad, rather than the traditional behaviors that we've learned inappropriately to look at for all kinds of pain. So differentiating between the two. Looking for the number of sites is important. People with cancer often have more than one site, and unless you ask this question, will more than likely tell you the site that hurts most only, and not reveal the rest of the sites that are also causing discomfort. Looking for the cause is important, although when we can't find the cause, we still need to manage pain aggressively. A good history and physical helps to identify some of these issues more clearly. When we assess pain relief, we want to look at how effective the plan is in diminishing pain. How long does it take for the person to get relief? How long does it last? How much relief does the person achieve? It's also important to ask the individual what their personal goals are for pain relief, and then measure our success against the individual's personal goals. We want to know as much as possible about the effect of pain on the person. What is it that this pain is interfering with in the person's daily life? Assess activities of daily living, looking for changes that we might be able to make by improving pain management. Evaluate side effects and evaluate the plan overall on a regular basis. When do we want to assess? That's pretty easy. We want to reassess when pain is unrelieved, with new pain, when pain changes, before, during, and after procedures that cause pain, at each visit and at each interaction. Make it a regular part of every visit, and at transitions in healthcare. Those last two are areas where people become at most risk to have poor pain management. How can you succeed in your setting? Use a consistent assessment tool and use rating scales to measure pain and pain relief. Document your assessment data and communicate in terms of assessment data so that you're painting a clear picture of what's happening with the individual. Teach patients self-assessment. They do an awfully good job at reporting back to us the information we need to know to help. Teach them who to report unrelieved pain to, when, where, and how. With multiple providers, it's often confusing to figure out who it is that you need to report unrelieved pain to. Identify barriers up front and work to remove them. Let's shift gears for a minute and talk about using medicines to relieve pain. For severe cancer pain, opiates, specifically morphine, are the gold standard. And within using medicines, we have some principles for using them effectively. We want to make sure that we schedule medicine by the clock, on a routine schedule around the clock, rather than as necessary for persistent pain. Most cancer pain, about 90%, can be relieved using the oral route. So look very closely at reasons why you're selecting to change to technology. Use an equianalgesic chart when changing from one medicine to another or one route to another. Use medicines in a systematic way. The World Health Organization analgesic ladder provides us with a model to do this. For mild pain, the World Health Organization ladder suggests that we use a nonsteroidal anti-inflammatory drug to begin. As pain increases, we add an opiate to the NSAID. And as pain becomes severe, we increase the dose of the opiate to relief and may continue to use the NSAID if we wish. You may also add adjuvants like antidepressants and anticonvulsants for neuropathic pain, or other adjuvant medicines to treat specific symptoms that the person's experiencing. Adjusting medicines to individual response is key. Remember, our overall goals are for maximum relief, minimum side effects, and the easiest plan to follow. If you or I can't figure out the plan, it's unlikely that the patient is going to be able to figure out the plan at home either. Titration or individual adjustment depends on individual response. Each of us responds differently to medicines. Keep in mind that there is no standard dose for the use of opioids in managing pain. We can increase the dose to infinity. There is never a point where we need to stop and say enough. unless side effects are unmanageable after we've aggressively tried to deal with them. We also want to aggressively manage side effects up front. We know anybody who's on long-term opiate therapy will be constipated. Begin a prophylactic bowel management program with a laxative and a stimulant combined together right at the initiation of therapy, and monitor clearly in the same way that you would monitor pain and pain relief. Look for other side effects as well, although most people become tolerant within about 3 days to most side effects, including respiratory depression, at the initiation of opioid therapy. Teach patients to use medicines well. One of the things that I found helpful for individuals who are taking oral medicines, both long-acting and short-acting medicines for pain relief, is to teach them to take the long-acting medicine whether or not they have pain, in other words, scheduled around the clock. To take the short-acting medicine only if they have pain, to document what they have taken, and to check in with us periodically on their progress. We need to evaluate breakthrough pain in a way that helps us provide relief. If this pain occurs just before the next dose is due, that's end-of-dose failure, and we clearly need to increase the dose of the long-acting medicine. If it's incident pain, we need to pre-medicate prior to the incident. If it's random pain throughout the day, we need to provide medicine with short-acting timelines that allow the individual to function through this pain period. So what can you do in your setting? Is information about analgesics readily available? Are there policies for the use of technology? Make that information available so individuals can succeed. Put information about analgesics where people write prescriptions and prepare medicines. Send them by fax to physicians' offices if you're working in home care. Are there educational opportunities within your setting? Things like pain rounds, ethics discussions that discuss unrelieved pain, and other areas of expectancy that you can get the message out to people that cancer pain does not need to be a part of the package. You need to be sure your setting has clear expectations. So how can you help? You can increase the priority for pain management in your setting. Make pain the fifth vital sign. Increase its visibility by having clear standards. Share that information in orientation of new employees, and that includes the multidisciplinary team, not just one or two disciplines. Provide opportunities to update knowledge so that the knowledge and comfort with pain relief is similar to the knowledge and comfort we have with our annual review of CPR. Create a standardized assessment and use it well. Use rating scales to measure pain and pain relief. Identify clinical alerts, or what I call clinical stop signs, points at which you automatically stop and review the plan. Some of those may be when pain is unrelieved, when you see a situation where the individual with pain is not believed and their self-report is not used as the primary source of assessment data, or when you are experiencing practice based on old ideas, values, and myths. Our challenge is to effectively control cancer pain in a variety of settings. It really calls on us to be sure that we have the knowledge and skills to know how to relieve pain effectively, and that we teach that knowledge and skills to others, both health providers and patients, as well as their families. We need to advocate for effective pain relief across the disease continuum. Be a role model. Be a leader. As nurses, we have a profound impact on supportive care issues, especially the management of cancer pain. When we advocate for pain relief, we are advocating for a better quality of life for those under our care. Isn't that a lot of the essence of what we're all about as oncology nurses?
Thank you, Carol. That was a very comprehensive discussion on pain assessment. It brings up a lot of questions. Perhaps the first question is, what's the next step when narcotics don't control the pain?
That's a really good question. Often when people report to me that narcotics aren't controlling the pain, I really advise you to go back and reassess again and look at the plan. Have you titrated the opiate to effect? You haven't if the pain isn't relieved, or unmanageable side effects. Often we arbitrarily stop at a number that's just a number that somebody's picked out of the sky saying, okay, now we can't give any more. Remember, there is no ceiling on the amount of opiates. So if you increase the opiate to relief or unmanageable side effects, then your next step is to look at the person with pain. Is there an inflammatory component? Bone pain, for instance, often will respond to opiates and the addition of nonsteroidal anti-inflammatory drugs. Neuropathic pain may need the addition of adjuvants like antidepressants or anticonvulsants. Adding complementary therapies may help reduce the amount of medicine that you need to relieve pain. If you've tried all of those and you're really at the end of your rope, you need to know when to refer as well. Ask the pain experts, refer to a pain specialist if you feel you've gone through all of those activities still with unrelieved pain.
Thank you, Carol. Those are some very practical discussions. I'd like to ask one more question for you, Carol. Is there a place for things like relaxation and other non-drug therapies to relieve pain?
There is a clear place for things like relaxation. Non-drug interventions like the use of heat, cold, massage, exercise, relaxation, and imagery have been shown to decrease pain perception. They also increase relaxation, decrease stress, and most people who have a pain experience due to cancer are also under a great deal of stress. When you combine these interventions with the appropriate use of medicines for cancer pain relief, you get a really nice twosome.
Thank you, Carol. I think Carol's discussion and prior discussion by me bring up a lot of questions. I'd like to go back to the panel to address some of these. Carol indicated, for example, that we should consider the patient as the expert. I think those of us who are in the pain field are comfortable with that, but how do we convince our colleagues that that is really the case, that the patient is the expert? Debbie, you want to?
Well, if I had the answer to that, I'd be very popular indeed. It's highly individualized. I think using the rating scales and doing it consistently and documenting what the patient is saying and relating it to as many objective findings as you can helps to get the message across. Doctors and nurses are trained to look at objective findings, and since pain is a very subjective experience, we can't take somebody's blood pressure or a measurement that says how much the pain is, but consistently using the pain assessment scales and demonstrating that the pain is not relieved with whatever interventions are being done is one way to get the message across, and it's really a matter of being persistent, and nurses really have to take responsibility and not take no for an answer.
Yes, I think that's part of it, but it's a difficult task sometimes. We have questions coming in from our viewers out there. We've got another question from a viewer in San Francisco, actually via the internet. Question is, are there resources that we can recommend for training of nurses regarding supportive care of oncology patients? I know, for example, that many major cancer centers have training opportunities for nurses to come on a limited basis for a day or perhaps a week or so to gain some skills and observe cancer pain service or other supportive care service in operation. But anyone else on the panel know of any other types of resources for nurses who want to increase their skills in supportive care?
I think there's an excellent one, and that's the Ambassador 2000 program
Yes.
of the Oncology Education Services. And I think I've been asked to be working with it from the nutrition component, but it's really addressing nutrition, fatigue, and
Yes.
pain components, really a teach the teacher aspect, and I think that that's a very exciting new resource that's on the horizon.
And that's what the Oncology Nurse Society sponsored? Yes. Okay. Debbie, you know of any
Certainly the
resources?
Oncology Nursing Society itself has many resources. There's a position paper on pain. There's a special interest group that members of the society can join to be in touch with additional resources. One resource that I'd recommend that everybody have on hand is the Agency for Healthcare Policy and Research Cancer Pain Treatment Guidelines. And those are available by calling the 1-800-4-CANCER, the Cancer Information Service line, and they will send individual copies of those guidelines. That has the really hard work that was done by a multidisciplinary panel and the major recommendations for the treatment of cancer pain. And that is an important document that I think everybody should have available to them.
Questions often come up as to how to dose pain medications. Would anyone want to comment on how one might decrease or taper pain medicines when patients are in situations like after surgery when their pain is decrementing?
Well, that's one of the issues that I think we've gotten very good about anticipating how we make sure that people are getting adequate pain. But I think certainly being trained as a surgical oncologist, there's sometimes the issue someone's on very high doses, yes, and we take away the source of that cancer pain. Are there similar guidelines? You don't want to taper too quickly, but a lot of times I've been very impressed that once that source of pain is there, the needs can actually go down very rapidly, but you don't want to, it's a fine line, and I'd like to hear your expertise in that.
That's right. This actually is a situation that needs better study, but many of us in the pain community use sort of as a rule of thumb that one can certainly cut by at least 50% of the maintenance dose, and perhaps as little by as much as 75%, maintaining the patient on about 25% of their daily requirement as a way to prevent withdrawal, acute withdrawal.
Absolutely.
And then the patient can be tapered as appropriate. In fact, there are some analgesic guidelines, the age CPR guidelines and the American Pain Society guidelines on analgesic use, which give a sort of a detailed description on how to do that. That's a very good suggestion, question. Debbie, would you like to add anything to that?
It's very much the same as in reverse is the upward titration. You need to have careful assessment of the intensity of the pain and the side effects that the patient may have. Very often, if a patient is getting more pain medication than they need and that stimulus has been removed, you'll see more signs of sedation and drowsiness, and that's a good sign that you can continue to go down. But then you want to be able to stop the downward titration if there's a recurrence of pain. And you do that with a balance of medication that you might be giving on a continuous basis, as well as having something on a PRN basis available to them, because you obviously don't want a recurrence of the pain.
The PRN component is very important to assure that the patient gets adequate medication. We've had some good questions coming in from sites around the country, and it's not too late to participate by calling the 1-800 number that appears on your screen. If you haven't called in your questions yet, please do so now so that we may address these questions after the next taped presentation.
Good afternoon. My name is Faith Ottery. I'm trained as a surgical oncologist with a PhD in nutrition. And for the topic that we're going to be talking about today, nutritional oncology, cost and complication prevention, this is a very good set of areas of expertise. Certainly many of you are well aware of the cancer statistics for the United States in 1997, where there will be approximately 1.4 million new cancer cases and approximately 560,000 people who will die of cancer. It's been estimated that approximately 1 out of every 4 or 5 cancer patients in the United States who die of their cancer will probably be dying of the complications of malnutrition rather than the disease per se. This estimate of deaths due to complications of malnutrition actually translates into about 112 to 120,000 patients every year who are potentially dying of the complications of malnutrition during their cancer treatment. Certainly the issues of outcomes management, cost avoidance, quality of care are an important part of medical care during the 1990s. And it's become part of our lexicon and is something that we certainly need to be able to deal with on a day-to-day basis, both in terms of our research and in terms of our clinical care. We've known about the prognostic component of weight loss in all patient populations, and first documented in a quantitative way in the mid-1930s by Studley et al. In peptic ulcer disease patients. That was where we first started getting the information of that kind of gold standard of a 10% weight loss as being associated with an increased risk of morbidity and mortality, which has been confirmed in a number of subsequent patient studies. What's important is we've also known that a shorter period of time with a lesser amount of weight loss is equally important. Blackburn and Bistrian demonstrated in general hospitalized patients and published in the mid-1970s information that a shorter period of time and lesser degrees of weight loss had the same prognostic impact as that 10% weight loss over 6 months. They found that we have the same risk of complication and death in patients who have lost more than 7.5% weight loss during a 3-month period of time, more than 5% loss during a 1-month period of time, or greater than 2% loss during a 1-week period of time. Why this is important is, as we're addressing nutritional risk in the cancer population, is that the National Cancer Institute's toxicity criteria for weight loss includes very different weight criteria. In general, a patient may lose up to 19.9% of their baseline weight during treatment and still be considered a grade 2 nutritional toxicity, i.e. accepted and tolerated weight loss. This does not take into account issues of the rapidity of weight loss, as in the Blackburn and Bistrian data, nor does it take into account issues of the cumulative weight loss over a period of time. In addition, we have very specific data in the work of DeWeiss et al. That was published in 1980 and was a retrospective evaluation of over 3,000 patients with multiple different tumor types, multiple different treatment protocols, but all of whom were beyond the scope of curative radiation therapy or surgery. They were looking for prognostic components that would have an impact in determining how a patient was going to do during treatment. And this retrospective evaluation reconfirmed the issue of performance status, but actually found that those patients who'd lost more than 5% of their baseline weight in the 6 months prior to their treatment initiation or diagnosis across the board had decreased response rate, decreased survival, increased toxicity, and decreased quality of life. Importantly, DeWeiss et al. Also found that weight loss during this period of time was an independent prognostic indicator in those people who actually had a good performance status. Now, there's been very little data in a prospective way that has been available in the oncology patients to really look at outcomes per se. Now, we do know in the 1990s, as we're addressing healthcare reform and healthcare management, that issues of length of stay, cost containment, et cetera, are extremely important. While I was at Fox Chase Cancer Center as director of the Nutritional Oncology Research Program and the Nutrition Support Service, we actually found that the data that is available in other patient populations, suggesting that average length of stay is about twice as long in the patient who's malnourished as someone who has the same diagnosis but is not malnourished, we found exactly the same type of data in the oncology patient population. Looking at discharge diagnosis data from 1993 to 1994, we found that those people with all discharges had an average length of stay of about 5.8 days. When they had a discharge diagnosis of malnutrition and or dehydration, then the average length of stay went up to 9.4 days, and if it was malnutrition alone, where it was severe enough that it was an obvious component and the patient wasn't specifically admitted for dehydration, the average length of stay went up to 13.4 days. One of the important aspects, if we're going to be able to have a standardized way of being able to assess nutritional outcomes, we need to be able to have a good and standardized way of doing nutritional assessment. The Patient-Generated Subjective Global Assessment, or the PGSGA, has now been accepted as the standard by the American Dietetics Association for nutritional assessment of the oncology patient, and is widely used by oncology nurses, and has actually now become one of the primary components of nutritional assessment of the Oncology Education Services Ambassador 2000 program. Nutritional assessment has to certainly be, to be usable, has to be easy to use. It has to be cost effective. It's important that it can be used in multiple different settings, so that something can be used in an inpatient setting, outpatient, home care, hospice, clinic, so that we can be using the same tool throughout the patient's course. It's also important to be able to predict who's going to have nutritional problems, who has nutritional deficit, and who is going to be impacted by nutritional intervention. This will allow us to do well-designed prospective trials to be able to understand truly the role of nutrition in patients' care, so that we have the promise of improving their care, potentially markedly having an impact in terms of cost by addressing things in a proactive rather than a repletion mode, and that we can have also an impact in terms of oncologic outcomes, patient quality of life, and in the issues of managed care components of patient satisfaction.
The treatment of cancer cachexia can be quite challenging. The most successful method for handling cachexia is the treatment of the underlying cancer. For those patients who do not respond to cancer chemotherapy or radiation therapy, then pharmacological agents used for cachexia may be necessary. Unlike the abundant AIDS wasting literature, the diversity of pharmacological studies with cancer cachexia is lacking. In terms of cachexia management, there are several options available. In the appetite stimulant class, corticosteroids have been used for many years. However, controlled trials have demonstrated that the effects are short-lived, about 2 weeks. Use of anabolic steroids in cancer cachexia has only been studied in one randomized trial, in which it showed no benefit after 4 weeks of therapy. Another popular stimulant is cyproheptadine or periactin. This agent was studied in one randomized placebo-controlled trial, in which there was no differences in terms of weight loss. However, since cyproheptadine does possess serotonin antagonistic properties, it was beneficial in decreasing nausea. Dronabinol or Marinol has been shown to increase appetite. However, the side effects of Marinol limit the utility in the majority of patients. Of the above agents, cyproheptadine does decrease the nausea, and Marinol may be effective in increasing appetite and also decreasing nausea in cancer patients. Another class of appetite stimulants is the progestational agents medroxyprogesterone and megestrol acetate. Medroxyprogesterone, or Provera, has been shown to increase the appetite with lower doses. However, higher doses up to 1 gram orally every day, it has been shown to increase weight gain and also performance status. In the U.S., the administration of large doses of medroxyprogesterone orally would be difficult, since the highest dose available is a 10 milligram tablet. Megestrol acetate, or Megace, is the most promising agent available for the treatment of cancer cachexia. It has been shown to increase appetite and promote weight gain in adults and children with cancer cachexia. Even with traditional adult doses of 160 milligrams per day, megestrol has been shown to increase appetite and body weight in approximately 30% of the patients treated. In dose-finding studies, the 800 milligram strength has shown to increase the appetite compared to lower doses. However, the lower doses seem as effective as the higher doses in increasing the weight gain. I feel the goal of megestrol therapy is twofold. One, you want to find the lowest effective dose, and two, you want to minimize the side effects with megestrol. Some of the side effects you can see are some mild edema, impotence in men, irregular menses in women, also unusual side effects like glucocorticoid-like side effects. Other classes used for the treatment of cancer cachexia are the metabolic inhibitors and the anti-cytokine agents. Hydrazine sulfate, the metabolic inhibitor, and patoxyphylline, which decreases tumor necrosis factor, have been heavily publicized to reverse cachexia. However, controlled trials failed to demonstrate any benefit. Melatonin has also been shown to decrease tumor necrosis factor alpha levels, and in addition, melatonin allows patients to maintain their weight, but it does not promote weight gain. Since many of these agents have different mechanisms of action, I feel there needs to be more trials in cancer cachexia utilizing combinations of agents to achieve the maximal response. Based on the literature available, progesterol acetate is the most promising for use in cancer cachexia. I recommend to start at 400 milligrams or the 10 milliliters of the 40 milligram per mil suspension to be taken in the morning once a day and titrate every 2 weeks to the maximal response. Again, the treatment of cancer cachexia is challenging and requires the patient and healthcare professionals to work together to managing this distressing problem. Thank you for letting me talk to you today about cancer cachexia.
Thank you, Faith. That's a very good overview. You know, this topic of nutrition is one in which many healthcare providers are quite deficient in, so, and myself included. Let me start. We've gotten a lot of questions from around the country, but let me start by just asking you to summarize in terms of how we could encourage good nutrition and prevention of weight loss. What are some 3 or 4 or 5 basic things that we could do to encourage that in patients?
I think it goes back to what I had talked about in terms of the patient-generated subjective global assessment. We actually found that over half of the people who had said they had no problems eating truly checked off at least one other nutrition impact symptom. And so I think when we ask, are you having problems eating, they're saying, I can get it down, it stays down. So I think using something that really brings out those symptoms in a much more proactive way, I think, is important. I think the other issue is that supportive care, which was a term that was used earlier, is not something that starts at end of life and goes backwards. Right. It really has to be something that is there from the beginning, and that's why something like the PGSGA is so important in terms of really addressing that from the time of diagnosis. Very practical things. Certainly, good symptom management makes people stop losing weight. I think that we do have that data in a number of the different patient populations. But in terms of very practical things, and I think that's perhaps what you're asking, above and beyond the symptom management. One of the things that a lot of patients talk about is metallic taste. Now, if we think about when we eat, we don't put the food on our tongue. We put the utensils on our tongue. Interestingly, they're almost always metallic. So if people are having those complaints, to be able to actually use plastic spoons and forks, simple idea, works in a lot of people. I've found that probably about, we all know about the issues of smell. Someone may say, I hate your cologne, dear, but they do it in a nice way. But a lot of times no one wants to complain when someone's cooking that I don't like your food. And what happens is I find a lot of times people will say, yes, I think that I could eat that, but when it's actually in front of me, I lose my appetite. And so a lot of times it's the aroma of the food that's doing it, and the cold platter may actually be more loving for the patient, etc. I do think that the issue of control is a very important one of nutrition, and to make certain that the patient lots of times realizes that that is something he or she can actually do something to impact, and also for the family members, sometimes to back off a little bit so that they're not pushing, because it really does become a very heavy-duty, sometimes battleground in terms of some of those issues.
One of our viewers from Seattle via the internet asked a question which I think many people are interested in. Are there any specific nutritional products which can be used to enhance the general health and well-being of cancer patients, particularly when they're taking chemotherapy?
Well, again, I think it very much goes back to the products. I do, as a nutritional oncologist, I actually include many products as nutritional products. And certainly the aspects of sometimes using nutritional supplements in a can, in a box, a number of different ones that are available, that if you truly just don't feel like eating, that may be one of the things that can help. The other thing, though, I found is a lot of times appetite's much better in the morning, so that food should be used for enjoyment early on, and then perhaps the supplements used later on. I think the other issue, though, is certainly appetite stimulants potentially can be used much more proactively, not just, again, at end-of-life issues, but certainly much more if the primary component is anorexia, that may be issues. You brought up the issue of metoclopramide. A number of patients who are malnourished will, in fact, have a problem of early satiety, so that may be an aspect combined with getting up and walking after eating may be helpful.
Is there any, back to the first part of the this presentation, is there any interplay between nutrition and the control of pain? Several people have called in with questions of this sort. Is there any relationship between nutrition and pain control in oncology patients?
I think that's a really excellent question, in the fact that certainly as we have people maintain their levels of activity, there may be more need for pain management because people are up, about, working, etc. Although there's some very interesting data in the fatigue component and symptom management database that we can actually use nutrition and activity interactively to actually help better eating, less nausea and vomiting, and therefore increase actually some of the endorphin components of pain management there.
Debbie, are you aware, for example, if weight loss or a greater lean body mass or loss of muscle affects metabolism or distribution of drugs, analgesics used?
I'm not sure I'm really qualified to answer that question. Certainly, a person who is whose GI tract is functioning better and who is more mobile is going to absorb things better and feel better. I look at the relationship of pain and nutrition as being very much interdependent and one supporting the other.
Sure. Sure. Yeah, well, we'll maybe have an opportunity to come back to that. Our next presentation will be given by Lillian Nail. After her presentation, focusing on fatigue as a side effect of cancer treatment, she will join us for comments and discussion.
Over the past decade, the interest in cancer treatment-related fatigue has increased dramatically. We don't know why, but it may have to do with increased efficacy of the management of some of the other common side effects of cancer treatment. However, there's a lot of confusion about cancer treatment-related fatigue, and the research base for managing fatigue is not yet well developed. One of the major barriers to managing cancer treatment-related fatigue is that families of cancer patients, friends, employers, and healthcare providers think that they understand the fatigue cancer patients experience. At this point, it appears that the fatigue of cancer treatment is different from the fatigue experienced by healthy people. And several years ago, a patient said to me, "You know, I feel really tired today, and people think sleep helps." And then she paused and laughed and said, "It does. While you're asleep, you don't notice it, but when you wake up, it's still there." And that's one of the key differences between the fatigue experienced by people undergoing treatment and the fatigue experienced by healthy people. It's not fully relieved by sleep and rest when it's cancer treatment-related fatigue. It's always there when people wake up. Another problem has been the definition of fatigue. There's a lot of confusion around, is fatigue the same as weakness? Weakness is a muscular deficit. It's best seen on objective testing. In contrast, fatigue is a self-perceived state. And one of the most helpful things is to think of it as being analogous to pain. It is what the person experiencing it says it is, and it can only be evaluated by the person experiencing it. It's not observable. You can't look at someone and tell how tired they are. Fatigue is a major problem in cancer treatment. It's now recognized as the most common side effect of treatment. In regimens like high-dose alpha interferon for malignant melanoma, it's a dose-limiting side effect of treatment. In various studies using different methods of measuring fatigue and using different patient populations, the rates of fatigue reported vary from 10% to 100%. This demonstrates the wide variability in the problem as well as the importance of the problem. A major challenge for healthcare providers is determining how they want to assess fatigue. Given the conceptualization of fatigue as a self-perceived state, it's clear that self-report is the preferred approach to assessing fatigue. Once again, the model that's used for pain assessment can be applied, where we ask patients on a scale of 0 to 10, where 0 is not at all fatigued and 10 is extremely fatigued, how fatigued do you feel today? There are other pieces of assessment that become extremely important, and one is examining potential causes. That requires extensive assessment of immunologic parameters, hydration, respiratory status, sleep, other ineffectively managed side effects and symptoms, as well as a variety of other problems like medication side effects and interactions. However, the cause of cancer treatment-related fatigue at this point in time is really not known. It looks like it's probably multifactorial, but what those factors are, we don't know yet. This creates a lot of challenges in terms of how best to manage fatigue. The first thing that we always suggest to people is that we prepare our patients for fatigue. There are a lot of different reasons for this. One is the research drawn from self-regulation theory, which clearly demonstrates that people who have information about what an impending experience, like treatment side effects, will be like, are better able to manage the situation. They have an accurate map or schema of the experience, so they know what to expect, when the fatigue is likely to occur, what it will feel like, and they may have received some information about how to manage it, but the key is that they know it's going to be there. They know that it's an expected side effect of treatment. This also addresses the issue of meaning. And fatigue for cancer patients has many different meanings. If you don't know that it's an expected side effect of treatment, you begin to think, well, fatigue can be a symptom of cancer. Does this mean that they lied to me about the prognosis? Does it mean the cancer is back? Does it mean the treatment is not working? These are major concerns for people and often not discussed with healthcare providers. Having the information that the fatigue is a side effect of treatment is going to help people plan for it, understand it, and place it in context. The other thing that patients undergoing treatment need to understand is what the pattern of the fatigue is like. And there are published data now about the pattern of fatigue in radiation therapy, where it tends to increase until the end of treatment and then gradually decrease over the months after treatment ends. For radiation therapy patients who have experienced fatigue, they're often told that the fatigue will end when treatment ends. It's a surprise to them when the day after treatment ends, the fatigue is still there. Again, there's the potential that they'll interpret that as meaning the treatment didn't work. And that's not an interpretation that most of them are comfortable with and not one they're likely to inquire about. For patients undergoing chemotherapy, the fatigue tends to peak a few days after treatment with cyclic chemotherapy, then gradually decrease. So the day of the next treatment is usually the day when the fatigue is the lowest. It's not clear if the base level of fatigue gradually increases over the course of several different cycles of chemotherapy, so that you never actually go back to the lowest level, if it's always a stair-step increase. Again, for people undergoing chemotherapy, the fatigue gradually decreases over the months following the completion of treatment. Many people talk about feeling like they reach plateaus. The fatigue goes down and then seems to stay steady for a while, then it goes down again and stays steady for an extended period of time. The idea of providing people with accurate information helps them plan for their experience so that they know what the experience may be like and think about how to fit it into their lives. And one of the things we often see in the West is that we have people who travel a long distance for radiation therapy. They may be ranchers who are driving 4 hours in for a daily treatment. They're not staying in town because they still have to run the ranch. They're driving 4 hours back home. There are no near neighbors or family members to take over the work on the ranch. Everyone is already fully occupied. This means that they're adding on another activity. If they don't know about the issue with the fatigue, they're not going to be able to make plans for how best to manage their life and plan how to keep their ranch going during the time they're undergoing treatment. The management of fatigue is grounded in the idea that physiologic problems need to be addressed first, that those are issues that we can address and work with effectively. One of the problems that's received a lot of attention in the literature is the problem of anemia because of the myelosuppression that accompanies most cancer treatment. We also see this problem in patients who have the chronic anemia of cancer that often accompanies advanced stage disease. Unfortunately, the research base on anemia and fatigue is extremely limited. The studies that have addressed the use of erythropoietin in cancer patients have looked at energy, which is related to fatigue but is not a point on a continuum, and also looked at overall quality of life. It's clear that reversing anemia improves quality of life. There have been no studies reported at this point in time that asked people for fatigue ratings and then correlated those with changes in red blood cell level. However, the clinical experience with people undergoing transfusion and with people who are getting erythropoietin suggests that this intervention may be extremely helpful. Questions like, how much change do you need to have in red blood cell level to notice a change in the sensation of fatigue still need to be addressed. Dehydration is also an important problem, as are electrolyte imbalance and many nutritional problems. These have not been studied in cancer patients undergoing treatment. There have been some studies done in palliative care. The relationship to the sensation of fatigue is also not known. The issue of infection is also an important one, and there's some anecdotal evidence to suggest that a sudden increase in the intensity of fatigue that doesn't fit in the usual pattern may be an early indicator of infection. A key element in managing cancer treatment-related fatigue is sleep disruption. Most of the studies of sleep in cancer patients have focused on the effects of noise on sleep. And while noise is certainly a problem for cancer patients, and it may be a significant problem for patients in the hospital as well as those who are treated on an outpatient basis, we don't know exactly how it fits in with fatigue. However, if you look at men with prostate cancer receiving radiation therapy who report getting up 9 times during the night to void, or people who've had surgery and every time they change position they experience incisional pain, it's clear that there may be a complex pattern of interplay among various signs, symptoms, side effects of treatment, and sleep disruption. The medical regimen can also affect sleep. When we instruct people to force fluids, there's an inevitable physiologic effect from that. And like the men with prostate cancer, they're up. We have people getting up in the middle of the night to take medication. This is also sleep disrupting. Hot flashes, nausea are all problems that create sleep problems. One of the most commonly suggested interventions for cancer treatment-related fatigue is energy conservation. People are instructed to decrease their activity to rest more. This intervention has never been subject to test, and we don't know if it's helpful or not. General clinical recommendations are to help people set priorities for their activities so that they select the ones they most want to do and also give priority to essential activities, as well as to transfer activities to someone else, if at all possible, or identify things that really are non-essential and can go by the wayside for a while. PT and OT referrals are important in helping people identify different ways of carrying out their activities so that they can conserve energy if that seems to be an intervention that's helpful for them. In contrast, one of the interventions that's received the most attention in the literature and has actually been subject to the most tests is the use of exercise as a treatment for cancer treatment-related fatigue. Exercise has been tested in women receiving adjuvant chemotherapy for breast cancer, and those studies are reported now. It appears to hold great promise. People who exercise in a study done by Victoria Mock had much less fatigue and better quality of life than those who did not. McVicker and Winningham at Ohio State studied a bicycle ergometry program and reported a benefit in the area of fatigue for exercisers. And there are several other studies ongoing, some with women receiving chemotherapy, others with women with breast cancer receiving radiation treatment. Nutrition is often looked at as a potential intervention. Data are limited. And Bernadine Simprich at the University of Michigan is working on restoring attention. For the future, priorities include identifying causal mechanisms, targeting prevention and treatment based on understanding cause, improving quality of life, and improving tolerance of aggressive treatment by effective management of fatigue.
Thank you, Lillian, for that very nice overview. We now have a few comments and a few questions for Lillian to comment on. Lillian, first of all, what is the cause of cancer treatment-related fatigue?
There are a lot of hypotheses about causes of cancer treatment-related fatigue. Initial thinking focused on accumulation of products of cell death. There are no studies that have answered that question. However, it appears that there are a lot of potential contributing factors. So for most people, there are probably multiple causal factors. Understanding the cause of cancer treatment-related fatigue is a high research priority, and it's going to help us understand ways that we can prevent and treat it.
Another question that comes up often is, can you tell us how we can differentiate fatigue from depression?
That's a really common question that people ask. The standard diagnosis of depression has really focused on a constellation of physical symptoms and affect. Most of the physical symptoms are things that are experienced as either symptoms of cancer or side effects of cancer treatment. So in cancer patients, assessment really needs to focus on affect or mood, a sustained feeling of sadness, inability to experience pleasure, rather than a focus on things like loss of appetite, trouble sleeping, and feelings of tiredness.
And one final question I'd like to ask that often comes up, are people who are told that they may experience fatigue, are they more likely to report it than people who are not informed about it ahead of time?
That's another really good question. A lot of the studies that focused on what happens to people when you suggest something to them were focused on artificial situations. In the 25 to 30 years of studies that have examined the effects of giving very specific preparatory information to people undergoing stressful medical procedures, and most of us would agree that cancer treatment is a stressful medical procedure, the people who get the accurate information about the experience have the same reports of symptoms and side effects and sensations as people who get the control condition or standard information that does not include symptoms, side effects, and sensations. The difference is that the people who had the accurate information interpret the experience in light of the information they received and experience less disruption in their usual activities. So they're able to plan for the experience better.
Thank you, Lillian. We have a time for a few more questions that have come in from around the country. I'd like to start a question from Jackson, Mississippi for Faith. Have there been major clinical studies involving nutrition's role in the treatment of cancer patients and in supportive care in a broader sense? And what drugs could you recommend for in your practice for enhancement of appetite?
Well, I think the first one, especially because of our time limitations, is to just briefly say something about the Society for Nutritional Oncology Adjuvant Therapy, which actually now is setting up a clinical network. And actually we have an 800 number, and that's 800-704-KNOW-IT, N-O-A-T, or 6628. Both for additional questions about nutrition as well as information about the clinical trials may be very helpful. And the other aspect in terms of medications that can be used in terms of appetite stimulants or orexigenic agents, there's an excellent article that came out in the June issue, 1997, of Nutrition and Clinical Practice, which specifically addresses an overview in terms of the use of appetite stimulants in cancer and AIDS. The one that really has shown the greatest promise in general has been the megestrol acetate in terms of cancer patients. The currently most widely used in terms of what's used in AIDS and cancer are really ones that are FDA labeled approved for AIDS patients, but oncologists using Megace oral suspension or dronabinol are being used by a number of oncologists.
Great. And moving along, are there any orally administered products that are easier for patients to get down and keep down for the treatment of weight loss?
I think the main issue is really to try and address what the problems are. There are certain ones that are more fruit-based, such that if someone has a lot of thick phlegm, that those types may be better for the head and neck patient population. Certainly people who have lactose intolerance, to make sure that those are issues. One other component that I think is important is any people who have problems with fat malabsorption, to make sure that those people, the stinky stool question that we need to ask, that the pancreatic enzymes can be used with that.
Mm-hmm. And important that those are important facts, and remember, we all have to be accountable for making sure that patients get good supportive care. We need to close now, and on behalf of MEDIVISION, the American Association of Critical Care Nurses, and Bristol Myers Squibb, I would like to thank the studio guests and our audience for their participation in today's program. We look forward to future discussions on supportive care for the oncology patient.
PRR Incorporated, the specialist in cancer information and communications, offering the latest information on cancer issues to physicians, nurses, and patients. PRR publishes Oncology, the country's leading cancer journal, and its supplements on advances in cancer treatment. Other PRR publications include Primary Care in Cancer, the only oncology publication dedicated to primary care physicians, with its editorial devoted exclusively to the issues of prevention and early detection of cancer. Oncology News International, the leading news source for cancer specialists, and Cancer Management, the official journal of the Association of Cancer Executives. In collaboration with the major international cancer institutions and organizations, PRR publishes textbooks for physicians, as well as educational materials for cancer specialists and patients, including today's most widely used breast self-examination guide. PRR also produces instructional videos and innovative interactive CD-ROM programs dealing with cancer-related topics. Stay in touch, stay informed with the publications of PRR Incorporated.